Assalamualaikum warahmatullahi wabarakatuh. So, good morning, everyone. This is our very first time meeting face to face. Very nice to see you all. My name is Rima. I'm from the Department of Parasitology, and I also involved in the One Health Task Force, Universitas Gajah Mada. So this is your very last day. How do you feel about it? You've been doing like a lot of activities since Monday, right? So how is
Recording
everything?
in
How do you feel
progress.
right now? Tired. Yeah, it's very understandable. Tired, but I hope you had a lot of fun this week. Before we begin with the presentation, I heard that some of you still needs time to finalize the presentation and everything, if I'm not mistaken. So we would like to give you about 30 minutes. Is that enough for you? I know it would. I know it would be enough, but 30 minutes for the last discussion with your group and then wrap up, and we will start with the first group or group one. Yeah. Make sure that the presentation you are going to present is uploaded on Elo, so we are going to share the screen, the one that you uploaded on Elo. Yeah, is that okay? Okay, great. 30 minutes. Begin from now. So the presentations will be about 25 minutes per group, 10 minutes for your presentation, and then 15 minutes for the Q&A. Your active participation is needed, so everyone can give some questions and comments or suggestions to the presentation. But please take note that this discussion should be encouraging your proposal to be better one. Okay, is that understandable? Okay, great. So we're going to start with the first group. The presentation, I think it's this one. Hang on. Can you share it with us, Mas Roy? Okay. Do you guys choose the same topic? You don't know. We don't know. Oh, nice then. Okay, so group one, where are you? So please come forward, facing your audience, and pitch your presentation and your idea about the implementation of One Health approach for integrated dengue surveillance system in Banda Regency. The stage is yours.
Cek 1.
Okay, hello, good morning, everyone. We are from Group 1. So today we are going to present our group project entitled Implementation of One Health Approach for Integrated Dengue Surveillance System in Bantul, Regency, Yogyakarta. So first one, I will present the introduction. Okay, dengue hemorrhagic fever, or DHF, remains a significant public health concern in many tropical and subtropical countries, including Indonesia itself. So according to the Global Dengue Surveillance Report compiled by the WHO in January 2026, there are a total of more than 180 dengue cases, new cases, that were reported worldwide. And among that, these cases, there are more than 400 were confirmed cases. So the continued occurrence of dengue cases across multiple regions highlights the persistence of global burden of the disease and underscores the importance of strengthening surveillance, prevention, and control strategies. And this is the economic impact by the Deputy Minister of Health. So Professor Dente has stated that the economic losses caused by the disease amount to approximately more than 15 trillion IDR annually, taking into action both healthcare expenditures and the loss of societal productivity. And this is the dengue clinical severity classification from dengue without warning signs into severe dengue. And this is the dengue virus transmission cycle. Next.
All right, before we jump into our proposed solution, so I'm gonna explain that dengue is a One Health challenge. So the dengue transmission is not only caused by human health problem, it is a combination between environmental, human, and also animal health. So, for example, the environmental health here, which are rainfall, temperature, humidity, urbanization, high population density, and also inadequate waste management and stagnant water, can create a suitable breeding site for Aedes species, which can raise the risk of dengue hemorrhagic fever cases. So So unfortunately, we identified some surveillance gap, which the current situation highlights that when the cases increase and then the outbreak has been declared. So after that, the intervention will be implemented. So there is a lack of preventive action. So we highlight some key challenges here, that the data remain fragmented across sectors. For example, the meteorological agency, they monitors rainfall, temperature, and humidity data. The health sector monitors dengue cases, important incidents, and also mortality. And the environmental sector, they monitors sanitation conditions, water management, standing water, and also land use. And the vector surveillance team, they monitors mosquito density and etc. But unfortunately, this data remains fragmented. But it is, I also will highlight that Indonesia has an existing initiative, which is the Indonesia Risk Calendar from World Health Organization, also Kemenkes, which integrates disease and meteorological information. And it is also supports seasonal preparedness planning and identifies high-risk periods. But also it has remaining limitation. For example, it's only a seasonal estimates, and it has no real-time integration of dengue cases, mosquito surveillance, and also environmental conditions and climate variability. So our objective is to develop a One Health-based integration early warning system for dengue surveillance in Indonesia by integrating human health, vector, and also environmental health and climate data into a centralized surveillance framework.
Okay, now I would like to explain the method of our proposed study. Next slide. First, our study is distinguishing the One Health approach, which aggregates human health, vector surveillance, environmental factors, and climate information into one surveillance system. Rather than analyzing each sector separately, this approach combines data from multiple sectors to provide a more comprehensive understanding of dengue transmission. We also apply multi-sectoral surveillance by collecting information from health facility, vector monitoring programs, environmental observation, and climate agency. Finally, GIS-based spatial analysis will be used to identify high and rise area and support an early warning system before outbreaks occur. Next slide. Okay, the surveillance system integrates four main source of data. The first is human health surveillance, including confirmed dengue cases collected from hospital, community health center, and the Ministry of Health. The second is vector surveillance, which include larva in the case, mosquito density, oviduct result, and breeding site information. The third is environmental surveillance, consisting of land use, sanitation condition, waste management, standing water, and vegetation cover. Finally, climate surveillance include rainfall, temperature, humidity, and seasonal patterns obtained from BMKG. Integrating these four data set provide a more complete understanding of danger risk. And we propose integrating wildlife surveillance data with existing data source from BMKG, the Environmental Agency, Dinas Lingkungan Hidup, and local public health center, Puskesmas. This integrated approach can strengthen early detection of ecosystem change and potential disease emergence.
Now I'm going to tell you about the data integration and analysis. How we integrate the data, we use two methods. One is SIGIS, and the other one is risk assessment and hotspot identification, in which we collect data and use these systems, and we get the early warning information. Next. We classify this framework into 4 parts according to the color. One is green, yellow, orange, and red one. In green, the risk is too low, and we do the just early community education. And the second one is yellow, in which the risk is moderate, and we do community education and management. The third one is orange, in which the risk factor is kind of high, and we use public awareness campaign, hospital preparation, and many other sources. And the last one is red, very high risk, in which the emergency alert are ready, and the hospital and the other health system are fully prepared. And these systems help us to identify the risk of infection and also reduce the transmission to the other persons. Yeah, thank you.
Okay, next is the result of the presentation. Okay, first is human health surveillance. We are using a data from article entitled Spatial Study of Dengue and its Association with Livestock Farming in Bantul Regency, Yogyakarta Province, Indonesia. From the article, available data that 302 dengue fever case, and then with a geographic coordinates of patients, and then the data is from 2021 until 2023, and then from this article have a distribution of dengue cases by village and sub-district. Okay, this is, if you can see on this slide, on the left side is area vulnerability level of the dengue, and then in the right side is a land cover map. So from the data, it's only collected from the 3 sub-district data, such as Kecamatan Kasihan, Kecamatan Sewon, and Kecamatan Banguntapan. Okay, this is, as you can see on this slide, this is a vulnerable map. The green is for a low risk of the dengue, yellow is a moderate, and then the right and the red is a high risk. From the data, we know that 52% of total area was classified on low vulnerability, and then it's only 10% just from total area was classified to high vulnerability. But it's may appear to be a relatively small proportion. Let's see closer examination based on the land coverage of characteristic. So from the vulnerability risk, we know that dense residual has a main character of the red area. So from the data we are collected, if One Health best integrated dengue surveillance dashboard, we are implemented in areas such as Bantul, what result we will be expected?
So how are we gonna see after the implementation of our idea? So before the implementation, we saw that dengue case data was stored separately across community health care centers, and environmental data were not integrated into a surveillance system, and climate data were not routinely utilized. So and also vector surveillance data managed independently. But after the implementation, we will see that dashboard is in One Health, and also it is monitored real time, and cross-sectoral data are integrated into a unified surveillance system. And also they are timely intervened before use escalation. Next. Okay, so what we will do after the surveillance, we'll target where the mosquito sources are very high. So we'll try to reduce the target mosquito source reduction, and also we'll use larvicide for reduction the mosquito, and also where the high risk that we cannot use the larvicide, we'll use fogging intervention to high risk zones. And also definitely community engagement and public health education is definitely important. And what we're gonna expect after this implementation, we're expecting that in the span of 3 years, almost 50 cases will detect in every 3 years span. Okay, next. Okay, so to do this, we have two types of goals. I mean, so this on short-term goal, and other is long-term goal. So for short-term, we'll use early detection in dengue hospitals, faster public health response and intervention, and reduction in high-risk areas, reduction in mosquito breeding sites, and decrease in dengue incidence and transmission. For long term, will reduction in dengue transmission within the community, decreased healthcare burden associated with dengue management, and sustained decline in dengue incidence over time. Early outbreak prevention through proactive surveillance and intervention. Thank you for having us.
Thank you very much, Group 1. Any questions or yes, please do not forget to mention your name and your institution.
Hello, my name is Hanif Ahmad. I'm from University of Indonesia. I'm very interested in your case application. How exactly do you map your risk areas? Do you rely on active surveillance where cadres identify your coordinates on the ground? Or do you use specific surveillance based on secondary data from health facility like Puskesmas? Okay, thank you.
Thank you very much. So about the surveillance, are you going to have an active surveillance or based on the secondary data provided by the Dinas? The surveillance that you mentioned and you told us.
Can we have a discussion?
Okay, great. Sure.
Strengthen the primary surveillance mechanisms.
Oh, anyway, about the submissions on ELO, would you mind renaming the file with the group on it, with your group on it? Thank you.
Okay, we are going to answer the first question. So basically, we will use combined data. Firstly, the fundamental one was the secondary data from the Ministry of Health and other specific government-related data. So therefore, we are going to really dependent to the active surveillance. So therefore, we will complemented the data by both active surveillance and also the fundamental by the secondary data. So maybe.
Yeah, hang on. Is that all? Do you have, is it good? Yeah, okay, good. Thank you. Yeah, please.
So my name is Mudassar Asim. I'm from MECOM University doing PhD there. Okay, so you mentioned that you have primary and secondary data and you have the cases. So what is the proposed solution? So for such, which I heard that when I came, people ask about me to protect yourself from the dengue. It's like common here. Okay, we have solutions for the humans and they are getting vaccinations from the hospitals. And what about the animals? I was like having a tour when I came for the first time. I saw in Gajra Mother University, there's like animal faculty there, so they started giving smoke so that they can protect the animals. So now you have you said you have a data, you have cases, you know everything, but what you have proposed solutions to them? For humans we have vaccinations, but for animals what? This is the question. And we said like is this summer courses for One Health, so what is like, okay, we have solution for the human, but what about the animals? Can you have like the answer on it?
The protection for the animals from the dengue virus. You need to be careful about the pathogen and the host animal. I mean, like for the dengue virus, you need to look forward. You need to look deeper whether the dengue virus is infected the animal or not. But for probably the protection will be more for the vector. Okay, great. Then.
Okay, thank you for the question. So, from what we discussed, how to like cure the mosquitoes, right? The vector, and how to protect the animals gitu. I have read a paper like there is a research about the genetic engineering of a mosquito, a kind of mosquito in one of the regencies in Central Java. They do the genetic engineering by engineering of a type of mosquito that can be released into the environment, that they can fight the Aedes mosquito that can carry the virus. So I think it is one of a come up with solution, but also we can do the prevention like cleaning up the environment and do the sanitation and like that.
Great. Yeah, please.
Maybe I want to add some point. So before, based on the lecture yesterday, that we know that emerging disease, one of the aspect is societal and behavior aspect from the human itself. So maybe like for the factor, like the protecting animals, it's mainly focus on the factors, how we can really control the factors, and it based on our daily life maybe, because the dengue, one of the factors is like a density and uncontrolled housing, and maybe we can really improve the condition by strengthening the cadre and also the community health base itself.
Great, thank you. So the surveillance here probably more about the vector as part of the One Health. So since up until now, finger crossed, dengue virus never infected the animal. Thank you. Last question from that side. Yes, do you want to do the sweet one? What lagi? Let's go. Yeah.
Okay, thank you. My name is Risna. I'm from UGM. I think you've mentioned before, maybe like from the previous question about the animal side, there is a new intervention called Wolbachia, and that intervention is being targeted the factor, the animal, and it's quite safe, but it take a long time to implement. And what do you think about the implementation of this? Because it's in the side of the One Health, it's not it's very effective. It's not it's not dangerous for the environment, and it's also bringing a very good aspect to human life, because they cannot getting infected with dengue, chikungunya, and Zika. They also targeted not only one specific virus, because they targeted in the Aedes aegypti. So it can like reduce a lot of infection from the Aedes aegypti. And so what do you think about the implementation of Wolbachia? Because you haven't mentioned it in your proposal, and I think you need to mention it because it's very important. Yeah, thank you.
Do you have any response to the comment? Yeah, more likely it's a comment. And it's becoming very quiet now. The implementation of Wolbachia. We have Dr. Edwin. Dr. Edwin Wines also involved in the World Mosquito Program in Yogyakarta. Behind. And Dr. Alvin is also the expert for the mosquito, so you can have more questions and more discussions with them later on. Yeah, have you found the answers or the response for Marisna's question for the implementation of Wolbachia nowadays? Wolbachia is proven effective.
Right. So thank you for the question. I think it's more like a comment, like whether this prevention or this system will remain effective if the factor is Wolbachia, right? The implementation.
So Wolbachia is like an intervention where they injected Wolbachia bacteria into the Aedes mosquitoes, so they cannot carry the dengue.
The virus.
The viruses, yeah. So maybe it's a little bit different with one you said. You said before that there's
Yes, sir.
in Central Java, I think,
Right.
sterilization. I think that's a sterilization, and it's quite different with Wolbachia because from the sterilization, usually they sterilize the male mosquitoes so they cannot breed, and with the Wolbachia, they inject the bacteria into the mosquitoes so they cannot carry the virus. Yeah.
So you ask like if we inject bacteria like Wolbachia into the dengue, will it affect the environment like that?
Yeah, don't worry. It's just another suggestion. We can take a look more deeper about the Wolbachia intervention. We also have Dr. Edwin, but I would like to pass this question to Dr. Edwin that actually
thank you
Wolbachia
so
is the natural bacteria found in the insects, but how it works and everything, we will have another 50 minutes lecture because of the time. I think that would be all for the group one. Please give your biggest applause to group one. Thank you very much, Group 1. Now you may back to your seat for the proposal. I also have more questions like why it should be in Bantul instead of any other parts of Indonesia. And then how about the outbreak cases found in Bantul? Is it necessary to conduct the research in Bantul? But we shall move on to the Group 2. Please make sure that you only have 10 minutes for presentation. 10 minutes for the presentation, and we will have more time for the discussion. So Group 2, the stage is yours.
Thank you. Handphone.
We found a phone.
Please come here.
Whose phone is that?
Sit. Please. Okay. Thank you. Good morning, everyone.
Good morning.
Hi. Okay. First, I will introduce ourselves, our team. We are from Group 2. There are me, Asol, and she is Risna, she is Aini, she is Anggraini, and he is Faisal, and the last one is Dev. Okay. Okay, guys. In here, we will talk about what is it? Yeah. The title is Cysticercosis in Papua Province. So I think this is what is it? One of exotic disease in Papua and endemic disease in Papua, and let us to discuss about it. And please, if you any question about cysticercosis, ask to me. Ask to us. Okay. And I think for the introduction will deliver by Anggraini. Please. Yeah.
Okay, thank you, Mas Asal. So, we're gonna talk about the cysticercosis. So, what is cysticercosis? Cysticercosis is basically a tissue infection caused by a parasite, a tapeworm called Taenia solium. This is a zoonosis disease, and the intermediate host is a pig, and it can affect some of tissue like eyes, cause ocular cysticercosis, and subcutaneous tissues, and even the brain tissue. So we're talking about the cysticercosis in Papua, right? This case first detected in pig at Enorotali, Central Papua, on 1973, and the human seroprevalence ranged from 3.6% across district, and the pig seroprevalence reached 23.5% overall district. So this is the transmission cycle of the Taenia solium. If we take a look to the Taenia solium life cycle, it will develop to a cysticercise. And Taenia solium can cause two different conditions in human, which are taeniasis and cysticercosis. Taeniasis is intestine infection where a human consume or ingest cysticercise from the uncooked or undercooked pork, while cysticercosis is a tissue infection. Like I said before, it can affect brain and eyes and subcutaneous tissue because a human consume embryonic egg, and it will develop into cysticercise in the human tissue.
Okay, the next one.
Okay, thank you. So this is the problem that, especially the fragmented surveillance and biosecurity weakness about the cysticercosis, and there is a surveillance gap about these diseases that it's very hard to address until this point. And the first one is the human, animal, and environmental health sectors that operates separately. I think it will be same with the others presenters that will say that there's a lot of diseases that have separate operation where they doing their surveillance system, because until now there's no equal surveillance to do the to close the surveillance gap. Especially when we talk about human and environmental, they have like different surveillance, and they rarely combine the surveillance to see what cause and what will happen if they have that. And there's no integrating of the clinical case, animal serosurveillance, and environmental data, and there's no early warning system to detect the rising risk before the outbreak occurred. Because in this diseases, they usually can be detected after the disease already occurred to the patient. And for the biosecurity weakness, the reason why there is still a lot of diseases in the Papua, because in there is still a lot of free roaming pigs. So they people have pig farmers usually let they pig roam around the village to find their own food. So they roam around, and because of that, and there's a lot low sanitation due to the poor environment, because they live in the very rural area, when they have known to very limited to known knowledge about how to implement sanitation. Usually they do open defecation. They have a very limited water in there, so they practice this sanitation is very low, and they also have low awareness because they didn't think that what they do is something that will affect their health. They do what they do is what the people before them already do. So, and they see that people doing the same thing but still being okay. So that's why they have low awareness and weak enforcement, because there's no policy for them, and the people from the government have a hard time to reach them, because they somehow listen more to their head of village rather than the government. Okay, next one.
Okay, this is the method section of our study. Instead of focusing on the single surveillance, we just focus on 4 different surveillances at the same time to make it convenient for One Health approach. So this surveillance framework, which we integrate from the biosecurity as a core component. So this one, which includes the human health surveillance, environmental surveillance, animal health surveillance, and the biosecurity surveillance as well. So to make the long story short, in the method section, initially we just focused on the data collection in the hospitals or in the community as well. So after the community-based reporting, we have to focus on the environmental surveillance to check out the sanitation infrastructure mapping and the water quality and spatial data collection. And after focusing on the human health surveillance, we just get into the environmental surveillance and then focusing on the animal health surveillance, which focusing on the population density, according to the population density, and we have to check out the roaming around the pigs over there. And finally, we have to focus on the biosecurity surveillance. So we have to make sure that we have to implement the biosecurity surveillance on the cysticercosis, which includes the community knowledge assessment and behavioral surveillance as well. So this is all about the method section. Next.
Now for the results. So there are some factors that lead to the persistent transmission of cysticercosis in Papua. The first factor is free roaming pigs. So usually pigs are free roam, and this is really risky because they can consume the human feces that already contaminated by the Taenia solium X and sustaining the parasite life cycle. And then the second one is inadequate fencing. So lack of fencing allows pigs to access contaminated environments and mix with other animals. The third factor is poor sanitation, limited latrine coverage, especially like toilets. It could increase the environmental contamination and pig exposure to the human feces. And then the fourth one is low community awareness, where the farmers and household community have limited knowledge of the transmission of cysticercosis, and it could lead to the persistent transmission of cysticercosis itself. And the last one is weak enforcement. While our government already have the biosecurity recommendation, but the implementation and also the monitoring still low, and it remain inconsistent across the district. Now, in this slide, highlight some districts that still have the cysticercosis transmission in Papua. The first one is Kota Jayapura, Kabupaten Jayapura, Kirom, Biak Numfor, Sarmi, Kepulauan Yapen, and also Central Highlands. All of the area mainly have the high-risk status, but for the Central Highlands, it have the highest risk status. Mainly the factor that leads to this high transmission in this area is the free roaming pigs practice, and also the high mobility, and also all of them are located near the cross border, so it could increase the transmission of the cysticercosis. But for the Central Highlands, it's more complicated because they also have like poor sanitation and limited health infrastructure that worsen the transmission of the cysticercosis.
Okay, for the next is the implementation of the biosecurity awareness strength range. There are 5 levels. The first is the community education and awareness. It's need a social approach, such as using ethnography research. So far, since I have gathered much data, so I don't want to comment further. However, the habits behind its spread needs to investigate it, such as undercooked meat. They cook using hot stone, a traditional stone grilling methods at temperature below the minimum need to kill parasites. And they also don't use protective equipment while raising livestock. We need to find out why these habits persist, since this is very much cultural in nature. In addition, we also need to engage with local tribe, known as Ondo Afi. Many anthropological studies show that Indonesian community are highly dependent on spiritual figures or leaders. So by collaborating with these figures, it can control the disease. And for the next so for the next level is infrastructure and technical support. So yeah, we need give more attention to this part if this proposal be implemented, because this is a corruption fields in Indonesia. Yeah, because it's si pengadaan, it's part of pengadaan, yeah. Procurement.
Yes.
And maybe the conclusion.
Okay, the last, please. Okay, for the conclusion, cystic cirrhosis persists in Papua because the transmission cycle remain unbroken and biosecurity weaknesses among local pig farmers are central to the failure. The Papua Provincial Agriculture Service or service acknowledge that pigs are predominantly free roaming, not confined, and that sanitation infrastructure is inadequate, allowing the parasite to complete its life cycle uninterrupted. And then an integrated early warning system that explicitly incorporate biosecurity surveillance to monitor confinement practices, fencing, waste management, and farmer awareness can provide early signal of increasing termination risk before clinical cases emerge. And the last, strengthening biosecurity awareness and implementation require a comprehensive approach. Participatory community education, infrastructure support, incentive structure, regulatory enforcement, and multi-sector coordination. Okay, thank you. That's all for us. Yeah.
Thank you very much, Group 2, for, I think this is very interesting disease that you brought to us about the cysticercosis and considered as the neglected tropical diseases. One question from the participants? Yes, from that one. Silakan, Mbak.
Hello everyone. First of all, thank you for your opportunity. My name is Jessica Natalia Kristiani Hartono, and I'm from Gadjah Mada University. I think this proposal is quite interesting, but I have one question. How long do you think it will take to successfully implementation on this proposal? Or like, is there any time frame to prove that this proposal or the program will effective or not? Because I think this program would be giving so much impact on Papua. So I think it's really need a quiet long time. And for my question is, how long do you think it will take to successfully implementation? Thank you.
Okay, can we answer?
Sure.
Okay, thank you. For us, I think it will take quite a long time, because not only it's about implementing a program, but it also about changing their behavior. And changing their behavior cannot be done in a short time, because we need to influence them to do it for themselves. Like the professor from, I forget I think it's from the second day, the one that said sustainability is not imposed from the outside, but it needs to be done from the inside. So we need to help them to realize about the problem that they until now that they didn't realize. And I think it will quite take a long time, but we need so much help from the head of the village. Ondo Afi, to help them. So we need to convince the Ondo Afi first, and when we already convince the Ondo Afi, they can help us to help us to make them to tell their villagers to change their behavior. So yeah, we don't have that kind of time frame, because I think if we talk about behavioral changing, we cannot set a time frame for that. Yeah, thank you.
Thank you, Mbak. Yes, from the side.
Okay, thank you for the opportunity. My name is Farabi. We often heard about cultural and community aspect plays a significant role to One Health approach. And according to this case, Group 2 case, what do you guys think and concerned about implementing more like a pilot project or wilayah binaan in a specific area or region in Papua specifically in Central Highlands, mungkin wilayah Papua Pegunungan ya. Because the region itself kind of isolated from outer regions in terms of infrastructure and others. So what do you guys think about that? Because the Central Highlands has the highest risk.
So yeah, maybe there are some cultural challenges that will lead to the to hinder the program implementation. But we believe that if we have like specific strategy to, for example, we first need to talk and discuss about the problem with the Ondo Afi or the key stakeholder there. If we talk about the problem itself, we are the Ondo Afi already know about what should to do. It could help us to communicate better with the community. So we believe that even though there is some cultural challenges, some strategies, especially to approach the key stakeholder, it will be important in these cases. Is it
Okay.
already?
So
yeah?
do you guys agree or disagree to like for the first one to implement this project from the highest risk region like Central Highlands? Yeah.
Yeah. We agree. But oh yeah, I also forgot to mention not only approaching to the key stakeholder, but it also need to be followed by the structural development there. So yeah, it's also important. Yeah, we believe that we have to address first the highest risk area, and then we move to another area.
Thank you so much, Group 2.
The last question from participants.
Hello, my name is Ikra. I'm from Unair. My question is, if we focus on our surveillance, how we manage funding and how many communities we need to participate? Funding and how many communities we need to participate in this?
Yeah, regarding the funding, I think it depends on the government policy. So we have to just focus on the government policy and regarding the funding. So regarding the funding, we cannot say anything at this time because it depends on like the finance situation. But
You have to give us estimate like this funding to this. Yeah, how we will implement this.
because like to say on the financial situation, it depends on the collaborators, the researchers, and the participants as well. So we cannot decide like this finance is enough for this project. So as long as it's regarding the collaborators, so we have to discuss on the finance situations. But regarding how to control on such kinds of things, yes, we have to focus on as a researcher. But regarding the finance, I think we're not the right person to focus on this budget is enough for this one, but we can estimate, but it depends on the collaborators and the government policy, I think.
Yeah, how many communities we need to participate in this?
I think we cannot answer.
I mean, how? What's the focus?
It's like the villagers of the high risk and area that we are going to target it. And I think I'm going to add a little bit for the funding. And I think for the funding is we can only give suggestion to the local government for that. So it's up to them that to make the funding for that, because we cannot fund the project for ourselves, but we can suggest the government how to address this problem, because if this problem is their problem, actually, yeah.
Thank
Great.
you.
So thank you, because public health problem is everyone's business, right? So
Yes.
everyone should involve and solve this one. One last question. We have Dr. Alvin. Dr. Alvin, you want to confirm or suggest one, two thing? Now I realize that there are a lot of experts attend this meeting. We have Dr. Farah, Dr. Alvin, Dr. Farida, and Dr. Edwin.
2 menit lagi.
Thank you for your help.
Did you ever go to Papua?
Okay, I think it's very interesting presentation from the group 2. Maybe one suggestion, if you want to do surveillance mainly in remote area like the highland in central Papua, you need to approach the chief or Ondo Afi, yeah, approach the chief, and also maybe train some local people as cadre, so they will have more awareness to the disease. Train them to identify the symptom, so you will have a clear target for the surveillance if you want to using serologic examinations for the seroprevalence. I think it's all my suggestion. Thank you.
Thank you very much, Dr. Alvin. Give your biggest applause for Group 2. Thank you very much, Group 2. And now we are moving on to Group 3. Group 3 will have a presentation about disease prevention and health management. This is so interesting how it will be presented to all of us. The microphone is on the table over there. You can use the pointer to move the slide as well. 10 minutes for the presentation and 15 minutes for the discussion. So 10 minutes, start from now. Yeah. Oh, please use the microphone, but
Hello guys, good morning. First of all, Assalamualaikum warahmatullah. So we are group 3, and in group 3 who are I am Mohammed Arif from Pakistan, then Hamza from Palestine, then Yamin from Myanmar, and Maria from NTT, and then Shafa from Indonesia, and Anissa. Okay. So our topic is actually about the integrated approach to disease prevention and health management, vaccination, monitoring, and biodiversity. It's actually based on the field visits that we have done over the past 2 days in the Wonokarto village and Turgut tourism village in Sleman Regency as part of our One Health summer course. So our presentation actually focuses on the interaction that human, livestock, and the environment health interact within livestock production systems, and how integrated surveillance can strengthen disease prevention and early detection of the zoonotic diseases in the livestock production. Next slide. Okay. So next slide is about the zoonotic disease. What is zoonotic disease? A global health challenges. Actually, according to the WOAH, approximately 75% of the diseases in human actually come from the animals. Infectious and disease such as like avian influenza, swine influenza, brucellosis, leptospirosis, and antimicrobial resistance infectious demonstrate how pathogens can move between animals and humans, affecting health, food security, and economic stability. In poultry, if you have like observed in the Wonokarto village, we have seen that how people and the animal live together in one setting, right? So when animal and density is high and biosecurity measures are inadequate, the risk of disease spillover increases significantly. So how does it relate to the One Health concept that we have done in this summer course? To address these challenges, the One Health approach recognizes that human, animal, and environment health are closely interconnected because human professionals monitor disease in occurrence in humans, hygiene practices, and community exposure to the disease. And then veterinarians focus on livestock health, productivity, and disease detection in the animals. And then environmental specialists, they assess factors such as water quality, waste management, and habitat conditions. By working together, these sectors can identify potential health threats, earlier risks, and improve preparedness against emerging diseases. Okay, and then what are the challenges that we have observed through our field visits? Actually, we have observed that there were the first from our team A, we have observed that there was a bapak and he was just living closer to his poultry farm, and it was so dirty if you have observed it, because there is no sanitation. And when we asked him, he said that there is no immediate how to say it, after working he does not have any immediate facility to wash his hands. He has to go inside and then wash his hands with the dishwasher liquid. And then the second, also the woman, she was the cattle keeper, and we have seen that the waste is just deposed close to the animal, so it has a high risk of infecting the animals as well as the human. Okay, next by Anissa. Okay.
Study objective. The first, assess existing surveillance practice and identify gaps in poultry and livestock production system. And the second, evaluate risk factor that might facilitate zoonotic spillover within this setting. And the third, develop a One Health-based surveillance framework integrating animal, human, and environmental health information. The fourth, provide recommendation for strengthening early warning and response system. And study location, our fieldwork was conducted in 2 locations within Sleman Regency. The first location was Wonokerto Village in Turi district, where livestock production is closely integrated with residential area. Observation focused on goat, sheep, duck, and chicken to understand interaction among humans, animal, and the environment. The second location was Turgo Tourism Village in Pakam district, located near Mount Merapi. This area contains both human settlement and natural habitat, making it suitable for observing wildlife, particularly wild bird, and potential indicator of ecosystem disturbance and zoonotic risk. Observation and data collection approach. Data collection was conducted through direct observation and semi-structured interviews using a standard One Health worksheet. Okay, next.
So there's One Health assessment framework for the.
Can we just skip it?
Can we just skip that? Okay. For the analytical approach, we have 4 main steps. The first is observation and interviews.
Down to the community profile.
Okay.
Like
Next, please. Okay. So the local community relies primarily on livestock farming and vegetable cultivation. Like several positive practices were observed, and the community demonstrates strong social cohesion and actively exchange knowledge related to agriculture and livestock management. And for the animal waste, was reused as organic fertilizer, and health education was accessible through the local puskesmas.
Oh, it's me. Yeah.
Next slide. Next slide. So we have 3 findings.
human, animal, and environmental. For the human finding, there is a good point because they know how to wash hand properly. But for the station, the hand washing station is not adequate. For the soap availability, it's a bit inconsistent because some of them have like knowledge in place to have like soap and some of them don't. And for the household sanitation, like despite all these gaps, they're like generally adequate. And for health promotion, thanks to the local Puskesmas, Pusat Kesehatan Masyarakat, they provide the materials and health promotion education. Next slide. So for the animals, since humans and animal like share the same space, there is spillover risks, and access to the services from the bats is very limited. And yeah, they rarely go to the services because maybe it costs too much or maybe it's far. And for the antibiotic, they have the knowledge for AMR, and there is no regular monitoring. They only go to the Puskas Hewan or to the services for from the bats. Like if there is something, how can I say, if there is an animal which is sick, and there is no formal animal health records maintained, and pool waste management, yeah, there is untreated tanks. For the environmental, as usual, for the cultivations, like human, animals, and the environmental, they share the same space, the same interface, and share water source. They get all the water from Kali Urisau, like used by both community members and livestock. And domestic wastewater, it's individually managed by household. There is no sender. And for the solid waste, it's only conducted via open burning near homes. And they're gonna ban, like if there's a solid waste. And highland location reduce the flooding. Because they live in the high mountains or highland, there is no risk for flooding, so it can prevent the mosquito-borne diseases.
So, from our finding reveals both strength and also vulnerability. Community strength including strong in social engagement and also good awareness in AMR, limited antibiotics use in livestock, and active health education from the Puskesmas. However, we still have several risk factor, includes proximity between livestock and the household, limited veterinary services, and then incomplete hygiene infrastructure, shared environment resources, and also limited integration among surveillance sectors. Addressing this risk is essential for preventing future zoonotic disease because, time's up? We still continue, right? Okay. Next slide. Okay. So this slide illustrates how integrated surveillance can improve early detection from spillover diseases. For example, increased poultry mortality may first be observed by the farmers, and then the laboratory testing could confirm the circulation of the pathogen, and then monitoring environmental may detect the contamination around the livestock and also for the facility. And at the same time, healthcare providers, may identify respiratory symptom amongst workers. When these signals are analyzed together rather than separately, authorities can detect threats earlier and then respond more effectively. So this demonstrates the core of One Health approaches. One Health surveillance approaches system. So for these findings, we have several recommendations, but I want to emphasize on the yellow one because it will we will emphasize on that. The third is establish the integrated surveillance framework, combines human, animals, and environmental health information within a centralized platform. So all of the recommendation you can read it, but we want to emphasize on the third. Okay. Next slide.
So according to the source and the indicators for human, environmental, and animal, for the human respiratory illness clusters, verbal illness cases, occupational exposure report. For the environmental indicators, الwater, الwaste, and الwater and الwaste, الwater contamination, الwaste accumulation, wildlife presence near farm, animal indicator, sudden mortality, reduce productivity, and the clinical sign of disease. So for the data collection and information flow, the data collection, then after we collect the data, we will make like local reporting units to send it to the local reporting units, and then district surveillance center, national One Health platform, and we can assess the risk by dashboard. Early warning alerts, it's very important. The risk factor included polarity, density, livestock density, animal movement routes, wildlife interaction zones, the human population density, environmental contamination, historical outbreak records. For the GIS tool, we will be used to classify area as low, moderate, and high. So alert level, we know that about how it divides into 4 parts or 4 structure: green, yellow, orange, and red. We know the green, it's been a normal condition. Yellow, increased risk indicators. Orange, confirm pathogen detection in animals. Red, it considered like a serious condition, suspected or confirmed spillover into humans. Automatic notification should be sent to the health authorities, veterinary authorities, and environmental agencies. So this the reference, we use it in the right of this presentation. Thank you so much, and we apologize for to make this presentation late. Thank you.
Thank you very much, Group 3. I think you mentioned several stakeholders that should be involved, but I also recognize that there are some Indonesians in this group. So I think it would be better if you can be specifically which kind of dinas or ministry that should be involved that would be more, applicable for the studies. Okay, any questions from the participants for the Group 3? Yes.
Okay, so you are already familiar with me, like Mudassir here from MBCom. So you mentioned that, okay, you have visited the places, okay? You find out each and everything. Let's just move on it. So you mentioned, Mr. Arif, you have mentioned that there's a guy who was like a bit dirty and he was washing hands with dishwasher, something like this. So my question is that, do you remember on third day, the professor mentioned about the some sort of awareness program. So to be honest, I got shocked when I heard that the guy was washing his hands with his washer or something like this. So I got shocked. I saw roads there, and I saw like people they are riding on motorcycles, we call like bike. So I got shocked. Why still they don't have such facilities there? Okay, you have a problem there, but you should give awareness. And the second thing that shocked me, like you said, okay, they have water, they have everything. So the people have water to wash the snakes. We saw the snake over there, but they don't have like the sanitization facilities over there. Why? So why don't you think your surveillance system would work on awareness rather than like proposing a solution to the animals? So it should be awareness to the peoples, not to the animals. How do you see this question?
I think what you said, that surveillance does not mean that we should put cameras or something like that. We should give them awareness, right?
Definitely.
Yes. So of course they does not know before coming over there, even though they have like a 500 chickens. He every day goes there, but he does not know how should he biosecure himself So that's why we go there and to give surveillance and take data from there. And that's why we're suggesting that even though there are they have poultry, they have livestock, why there is no facility? Because of the remoteness.
Mm,
Yes.
yeah,
Maybe.
kind of.
Okay. Thank you.
So basically, like surveillance can be started from the from the lowest level in the community, so they aware which one is the normal condition, which one is the abnormal conditions, right?
Yeah, I think the human are the drivers of the food security and the economy. So if the human security is not assured, so how will be the livestock or other things will be secure?
Mm,
So
mm.
first the humans comes the first, right? They are the drivers of the economy and the food
Mm.
security also.
Mhm.
Yes.
So it can be started from the
Yes,
awareness
of course.
for the farmer. Okay. Still no more questions?
No comment.
Thank you. Are you sure? Dr. Farida, Dr. Farah, do you have a question to group 3? Oh, ada satu ke peserta dulu ya, Dok.
Hello everyone, my name is Jessica Natalia Kristiani Hartono and I'm from Gajah Mada University. So I have one question. Since GIS can be quite challenging for communities that have never used it before, how do you plan to implement this system at the village level? Who will be responsible for managing and updating the GIS data? Thank you.
The GIS, thank you. Who's going to be responsible for that?
Okay, so for GIS, we want to map where is the highest risk and also the low. So the one who take the role to map all of the spread disease will be in the after the surveillance, and it will come out from after we did the surveillance. And I think there are several tools that can be managed by the community, and they can do it like participatory, but for the emergency situation, we cannot apa namanya, we cannot implement it. But after several, we saw yesterday from Professor siapa namanya Ahmed that he said that there are several initiatives that provide time management like 100 hari and then 7 days, 1 days and so on. So during that time, they can manage to use the GIS to mapping all the risk and all the spreading disease. Yeah,
So-
and can map the low from the low until the high risk of the spreading. Yeah, spillovers.
I think the keywords here is the community engagement then, right? Involving the community to participate for the surveillance so everyone can be aware and alert before it becoming too late, right? Yeah. I think that would be all for group 3. Thank you very much. Please give your biggest round of applause to group 3. Well, actually, after group 3, we are having a coffee break, but shall we have group 4 first before the coffee break? Yes, so group 4.
Boleh sih, dia kayaknya menargetkan kita jadi gara-gara nanya terus. Kita jawab aja. Saya nggak ngerti.
Yeah, please, group 4, your 10 minutes. Start now.
So thank you so much for giving an opportunity to present our idea. Though I'm like from computer science, but I'll try my best to pronounce some good words and then. Okay. So our like presentation topic is like an integrated early warning system for the zoonotics spillover. Oh, so this work is like motivated by Dr. Viramata. Yeah, so we had some presentation. We saw the presentation of Dr. Viramata about this, and then we thought like, okay, we should work on this topic because it looks similar to our like research that we like organized. Okay, so this system is like a working system. No, not system, the diseases. Okay, so the disease is like zoonotic is a spillover. So we have a bacteria which we found out in a soil. So the soil, it integrated with the plants. Then the plants are like, let's suppose they're like plants that the animals started eating. We take, in our case, is like sapi, cow, and then the cow is started like eating such plants, and then we as a human eat cow meat. Okay, so either it should be like whether it's slaughtered or like you can just eat it inhaled in your system. So this is like the whole integrated system. So from the soil, like from the environment to the animal, from animal to the human. So this like integrated, that's why we call it like one health system, and the rest will cover by my team.
I propose the methods.
All right, so yeah. So we're gonna start with the spillovers. We're focusing on Yogyakarta's. Oh, okay, sorry. Can we change to the newest presentation? Thank you.
Ini yang sebelumnya. Oh.
Okay, so until they get the right PPT, so I'm telling like why it is like One Health, because we have now problem. We know that it integrated with humans, animals, and environment. Then we have like proposed a solution in it. So you will see rest of the slides, they covered up this solution. So how we can like overcome these problems, and we have suggested some. And then based on what we observed during the presentation or from the presenters, we came on a conclusion, and you will be like get amazed to see we have the solution now, and we propose the system. And for sure, if the ministry or the university want to work, it can implement and to get better results.
It's okay. Group 4, would you mind if we have a coffee break first? Absolutely right. 10 minutes for the coffee break, and we'll be right back right after the break. Thank you.
How we will enjoy our coffee. Ah.
Nanti dia paling bilang kota Indonesia. Kalau misalnya sampai Rabu ya, berarti nggak pulang sampai Senin. Hari Senin capek, kalau misalnya makan kegiatannya, misalnya Senin pagi kalau misalnya pagi, kalau misalnya pertanyaan Kamis, ini juga kan ada soal kalau kalian berangkat ya. Nah itu pun naik Grab.
Hi, welcome back to the second session of the presentation for the summer course of One Health Universitas Gadjah Mada. Are you ready? Ready? Good. So please give your biggest applause for Group 4.
Satu, dua, tiga. I guess everyone enjoyed that breakfast. To be honest, it was too delicious. Okay, let's move. Previous slide. Yeah. Okay, thank you so much. So this work is motivated by Dr. Veratama. So the proposed approach that we are going to follow in our study case, which is like a anthrax case, and then we have like integrated approach for what we call zoonotic. Yeah, zoonotic spillover. It's like so they're like diseases and we have virus. So do you remember the professor said diseases are different and the virus are two like other things. So okay, next slide. Okay, so this systems is like works. How could I say? We have a bacteria there, as we cited earlier. As it's like you will find in the soil, and then the soil that it travel to the plants, and then the plants when the animals come, especially soppy in our case, when they started eating it, they got infected too, and after that we slaughter them or we are eating the meat of that cow, and we got infected too. So see, the cycle is integrated between environment, animal, and the humans. Okay, so yeah, so we have like the strategic animal diseases, which will cover by my friends. Up to you.
Okay, so on this case, we're going to focus on mostly the legal. So first, we want to share with you about penyakit hewan menular strategis or strategic animal diseases that is actually already being legalized in Kementan regulations. You can see the number there in the slide, and it refers to a high impact animal pathologies selected based on key criteria, which is first, high morbidity and mortality, catastrophic socio-economic consequences, and severe public panic. And the last one is significant zoonotic spillover potential, as we all know. Okay. And for our specific area in Yogyakarta here, we know, as we've seen yesterday during field trip, that they have high livestock density. We also put the data here from what we found in Situasi Case 1 in Yogyakarta, and it's heavily populated by beef cattle, almost 284,000 beef cattle, and then we have twice the number of beef are goats, 431,000 goats, and then there's also sheep, as we found in the in the rural areas. And we also have poultry sector that also have possible zoonotic disease spillover. And you can just see in the slides the numbers, yeah? So it's really, really highly livestock density. And we also have, based on the regulation, there's like 15 priority zoonotic diseases, and there are 4 types from bacterial, which almost 33%. There are anthrax, leptospirosis, bovine tuberculosis, and brucellosis. And then from viral, there are avian, influenza, rabies, and Japanese encephalitis. And then from parasites, we've mentioned a lot, and today too, toxoplasmosis, tetanus, and schistosomiasis. And this the new emerging infectious diseases that we've also haven't really quite understand yet is the Q fever and Campylobacteriosis. Yeah. Okay, so we're focused on anthrax and.
Okay, thank you. Continue. We focus about the anthrax. Anthrax is the bacterial zoonosis disease who contaminated soil, serve as a long-term reservoir and source of infection, especially in endemic areas. Of course, in Yogyakarta. From the data we saw in 2025, there is the massive increasing incidence of the anthrax in Yogyakarta. It's 42 cases in all area of Yogyakarta, from Gunung Kidul, Bantul, Kulon Progo, and also in Sleman. So we know together our government can carry out the massive vaccination, good health education in the community, and also, but why the cases is increasing? This is the big problem to solve. Next.
Okay, for the methods, we are proposing for this project, we are proposing the multi-agency integration framework with the purpose of to align all agency on one vision, the One Health approach. So these are the steps. There are 5 steps. The first one is we define share among the institution between the Kementerian or Dinas, and then we map the ecosystem. And the third one, which we secure the leadership mandate in the institution. The next step is we develop multi-agency of memorandum and understanding, and the last one is try to funding a vehicle for the program on health. We also recommend to optimize the data integration plan of CISE that including the three materials, that is human disease, animal disease, and environment parameters. We also propose to increase and integrated transit border sentinels in Yogyakarta, because there are only 7 checkpoints in Yogyakarta, so we have to increase more the integrated transit border sentinels.
Okay, this is more like the results from previous data that we found from the officials, from the current surveillance that we have. This is more like the chronological and the cycles of the occurrence of the anthrax, which is mostly year by year they found the occurrence of anthrax within the soil in Yogyakarta. That's why previously we mentioned we proposed a method that where not just we focus on the animals, but we also have to join between the agencies and officials, not just in veterinary, but in environmental health. For the discussion, we more likely to discuss the gaps in the policy, where there is surveillance and monitoring in anthrax and veterinary, but the real gaps that cause not optimize detection and surveillance is within the policy, which
Forgive me, I didn't bring my glasses up, so I'm gonna read off my phone a little bit. Okay, so some of the surveillance gaps that we see, we already discussed brand new in the lecture. So that was the practice where there was the community fund and the cattle would be dispersed across the community for a lower cost. And so that's already being discussed and taken care of. So we decided to maybe look at the Purok tradition instead as an alternative. So our field analysis identified Purok, the emergency slaughter, as the most critical socio-anthropological driver of human anthrax. And so this was the one when it was, they noticed that the cattle were sick, so they quickly slaughtered the animal and dispersed it for a very cheap cost around the community. And so a way to maybe mitigate this and like why there's a gap is because it's not being shared through the community on the educational front. So maybe if we started introducing it into the farmers' families and the schools and it was discussed more, then there would be we could limit that or what's the word? Minimize the gap. And then also with the systemic service gaps, governance gaps are driven by local statutory definitions. And so we are specifically looking at the veterinary animal health as the option rather than mandatory public service. So structurally causes inconsistent budget deficits, severe technical staff shortages, unmonitored backroad transit routes, and no official slaughterhouse. Okay, so some recommendations. We already learned that there are some strategies being implemented, including there is surveillance and there is education, but it's just not strong and there's always room for improvement. In a perfect world, we could increase surveillance, but like I said, we've already kind of discussed that, so we're gonna stick to the legal and executive framework instead, just to broaden it as a multi-pronged approach to this, because it is One Health, so there are many approaches we can take. So first, we can have the regulatory foundation, where local policies dictate operational lines in livestock management. And some of these key structures are establishing clear veterinary leadership and directing the regional task force for zoonosis. And so some of the specific interventions include mandating veterinary services, so public service, permanent structural funding, so that way there's never like we need money now, like we have a consistent flow, because with these situations, we know that it's pretty rare. However, in the state of an emergency, you don't want to have the outbreak and then all of a sudden people are getting sick and you can't control it. So you want to make sure that you're ahead of the game a little bit. We kind of discussed eradicating Purok via the microfinance, institute a community pooled compensation fund for sudden cattle mortalities, and replacing that financial loss, which is the economic driver to the slaughter infected carcasses. So we kind of already discussed how we could use the community fund to support the farmers so that they have more of an incentive to report the infected cattle. Fortified transit checks, which increasing the number of border patrols and checkpoints to utilize local police to monitor bypass routes and back roads. And then finally, formalize cross-agency integration, which is the digital automated data sharing pipelines between human health centers and veterinary centers so that we can connect all the components of One Health.
During the first day trip, I had some questions which I asked from the lady, and she told that the government is giving them like a vaccination twice in a year, and I said, okay, it's fine, but some are not, some vaccinations are not working. So it's like we have limitations to our approach proposed system. So we think like, okay, we now can work on surveillance system rather than so. To recapitulate it, I would say, so we have a system now. What we increase the surveillance system so that we can get health certificate to the animals, which comes from another like cities or like borders. So once we provided them, it will reduce the health risk of this. I don't know the disease's name, anthrax. Yeah. So that is all from our presentation. If you have question, discussion, always welcome. No.
No. Well, this is actually very interesting. When I heard about Brandu itself, and we talk about livestock, it's not only about the animal health, but other kind of factors such as economic also also influencing this kind of outbreak and everything. More questions? Dr. Edwin?
I have a question to myself, like to be because no one is asking. So to be honest, I saw like some of my friends, they are working in China, in South Korea. So they said they have like a good surveillance system.
Oh, yeah.
So whatever they're taking from the borders, from one city to another city, they just put kill in each and everything so that diseases cannot enter. This is how we can. So why we choose Jakarta? Because we saw some of the cases here. And that is why we propose our system to work in Jogja. So once it
true.
is finalized and if it is approved by the ministry, or if ministry want to work on this, so might be possible they can work on different like island as well.
Yeah, this is also very interesting. And I also heard about the pos lalu lintas ternak. Yeah. Are there any veterinarian among? No? No? Mas, dokter hewan? Bukan. Bukan. But that is also very important actually in theory, but in the real life, in the implementation, that pos lalu lintas ternak is also another dilemma in our in the real setting, since there is no main responsible or person in charge to conducting that pos lalu lintas ternak. But in theory, that pos lalu lintas ternak is very important to check the animal health before they move from one place to another place. Different from another developed country, we don't have any ear tag for the livestock, so we cannot trace those livestock that move from one place to another one. So when, finger crossed, when the outbreak happens, it's not easy for us to track or to trace down which area this animal come from.
Yeah, but to be honest, my university is already working on it. We have
Oh,
like
yeah?
animal intelligence system.
Oh, great.
So we will detect animal health, each and everything. So right now we are working. Might be possible within 3 or 4 years we'll get some results and we start implementing in Jogja. Thank you so much.
Oh, great. Ada pertanyaan lagi? Oh, sorry.
Yeah. Thank you so much for such a wonderful presentation. So my question is about Mudassir. Please look at here. Okay. You know, like Indonesian people really like to eat. If you go to one jalan, you will find tens or maybe more than 10 warung, and every warung has pile of chicken, right? So it means that there is so much supply from the sellers also. So in this area, so maybe thousands of sellers and maybe individual sellers. If you go to the market, you will see people selling ayam kampung. That means that they have a little scale individual chicken in their homes and they sell them. So how do you feel that in this so vast area, how can government with the minimum resources can detect animal health and other things?
Definitely, this is like this is like good question. To be honest, what we always start from zero. So our integrated system, let's suppose, is working on SAPI, then we can try to test on other things as well.
SAPI in which area? Because Yogyakarta have 4 districts. Yogyakarta city.
I don't know. I came
Bantul
last
and-
month, bro.
That's not a good excuse.
They support my idea.
Yeah, I think what we're focusing, you were mentioning markets, so that means the animal already slaughtered, right?
Mhm.
Yeah, I think what we're focusing, proposing is to focus on the live one. So during transport or during the translocation of the animals before they got slaughtered and being sold in market. I think that's the key. Since we already have the regulations, we already have some SOP procedures in place. We just have to strengthen it because and maybe enhance the communication coordinations, and like we mentioned, the one who's lead the whole process better, so we can have fundings and like better leadership basically to implement the monitoring surveillance.
I also just wanted to add that during this, we had learned that during the slaughter process, you can also become infected. So the farmers and those that are slaughtering the animals, like they don't want to become infected themselves, or like we don't want them to be either. So a lot of the times we also learn that they do know their animals are infected. That's why they try and get rid of it. That's the PIROC system tradition. And so if they are in the know that their animals are infected and they're trying to sell them quickly, that means there already is a little bit of knowledge, right? Like if they can see the animal's sick. So incentivizing the farmers to do it properly. And that's working with local ministries, it's working with maybe local universities to conduct research. It's those partnerships, I think, that will convince the farmers that there's a better alternative than to selling it and becoming infected or infecting others. But I think that's kind of like in a downstream approach, like that's the way that the system's moving. And so if we can stop it there, or at least mitigate it there, then it can prevent it to getting to markets and being sold. And then people picking it up on the yummy street food.
So to add this point, like what was the name of the food?
Which food?
Ayam
geprek.
Ayam geprek. So bro, just eat nasi goreng without ayam. You will not face any issues.
No, not all farmers selling nasi aja. So they what we see in the, like one farmer have 500 chickens and then other one have 400 ducks. So yeah, they're not only growing nasi only, right?
Okay, so they can sell it to the another city. Our study like on Jogja.
No, what I feel that that the market is so porous, right? It's so diverse, and there are like thousands, maybe millions of sellers. I don't know. But how in China that you have given the example, maybe the sellers are very only few people that are listed on the list, and that's why they control surveillance very effectively. But in here, it's very democratized. But maybe you can also have chicken in your course. I don't know.
Yeah,
like everybody is seller right here. So for the search of economy, so how it's very what I feel that it's very hard to put large scale surveillance in this case.
Definitely, you will see hard.
And the second seller, he said that he had ducks, and he was so incentivized because of the duck feed. He says it's very expensive and he cannot afford it. So how they are going to put money for the surveillance and other things? And I think it is very very hard.
Let me comment on it. So the government is on it. They are providing, they are like getting some suggestions from the PhD researchers. To be honest, one of my colleague from MECOM, he's working on like food, like halal food system. So they get the problem like you mentioned. So we need to figure it out, the cost and each and everything. So people of Indonesians, I saw they are still they started working. They now know the problems and they started working on it to get the solution. So it comes not only by the people, but we need support from the government as well, because the systems that we use or the tools, they are cost, but is like you cannot get alone. So you will get fundings from the government. This is how. And now which shocked me, like now in 2026 the Indonesian people, they started thinking about these issues and problems. So they are slowly working on it, and inshallah within 4 to 5 years they will have some solution on your problems.
Thank you.
Thank you so much. Thank you.
Anyway, so before we come up with more strategies, before we come up with more procedures or even the policy, we need to understand the natural
Cycle.
history of the disease first. Then we come up with the right intervention, with the right policy and everything. But that's a good one. Thank you very much. Ladies and gentlemen, group, oh yeah, please.
Sorry, I would like to respond about your Mbak MC comment about the checkpoint. Okay. For me, I connected it because based on data, it is increasing of incident anthrax in last year. So I connected it with the government efficiency funding. Yeah. So it's like the okay. It's kind of like the resource of our husbandry or agricultural department, and also for the services too in the operational especially.
Okay, that would be nice if we have someone at the government level and then told them, hey, we need more money for this one to prevent all of these infectious diseases coming up. Hopefully not coming as an outbreak, but that would be better as well. Thank you very much, ladies and gentlemen, Group 4. Group 5. Oh, very intriguing title. One Health at the Crossroad, the extreme market of Sulawesi, Indonesia. Okay. 10 minutes for your presentation and followed with the discussion. You ready? The stage is yours, Group 5.
First of all, guys, Assalamu alaikum. Myself, Huzaifa, and today I am the first one who will start this presentation. Today, really, I am really with high and that like heavy heart. We are on the crossroad of One Health. With this title, we have one topic about extreme market in Sulawesi. Yeah, as you know, it's really famous in all over the world about Indonesia. Indonesia have extreme markets. Not in Sulawesi only. We have extreme markets in Surabaya too and in Jakarta too. But today we are discussing about the extreme markets in Sulawesi. So what actually it is? Extreme market, there's the market where slaughters wildlife animals like snakes, rats, birds, and what can I say, bats, and so on. What I see about the data is about, wait, let me show. Yeah, from the journal, it's about 68% of wild animal slaughter in Sulawesi. In this 68%, like we have 80% boars, wild boars, and then bats 65%, and then snake 35%, marcos 28%, cascus 17%, and so on. It is cited by reputed journal. So next. Now you can see how delicious rat is. Next. Yeah, they are slaughtered different kind of dogs. Now, yeah, here your beautiful rat in from the house to the slaughter market, and the end is different kind of snakes and so on. So now I'll give to my friend to continue this.
Okay, right. Before we discussing each pillar, let me briefly explain what is the One Health is. According from the World Health Organization, One Health is an approach that recognizes the close relationship between humans, animals, and the environment. The Tomohon Extreme Market is a good example of this concept because these three sectors interact closely every day. Yep, and research show that about 68% of people have direct contact with wildlife, including rats, wild boars, bats, snakes, and monkey. Because of this interaction, there is so higher risk of disease transmission. Okay, now let's look each pillar. The first, the human pillar. This pillar focus on protecting people from genetic disease, improving food safety, and preventing future outbreaks. And seconds, we go to animal pillar. Yeah. This pillar focus on animal health, animal welfare, and controlling wildlife threat to reduce the spread of disease. And the last one, we go to environment pillar. Yeah, this pillar focus on sanitation, water safety, and maintaining a healthy environment to prevent pathogens from spreading. And finally, at the center, yeah, we have the One Health Nexus. It shows that human, animal, and environment health are connected. So to protect human health, we must also protect animals and the environment. Okay, maybe next.
Okay, well, the next is the intersection of the risks. Okay, for first, we will talk about the human health. So, when humans come into close, unregulated contact with this animal through handling, slaughtering, and consuming, the virus or maybe the bacteria can jump from the animals to the humans. And this is known as zoonotic spillover. Like we know that like Ebola, SARS, and COVID-19 maybe. And the next is the animal health. So we know that in markets where diverse live or freshly slaughtered wild and domestic animals are kept in close quarters. So the risks of this disease transmission among animals are secret stress and poor sanitation compromise their immune system. And last is about the environmental health. The surrounding environment, water system, waste management, and local ecosystem can become contaminated by waste, blood, and fluids from the market. So, conversely, environmental destruction like deforestation puts wild animals closer to human habitats and feeding into this cycle.
So this slide is highlight about the zoonotic diseases threat to human health. So zoonotic diseases is approximately 60% of all emerging infectious diseases globally. Then traditional market operates as early warning sites where close multi-species contact drive viral mutation and spillover risks. Diseases of concern include rabies, avian influenza, and Nipah virus. Yet recent study in 2020 shows other viral zoonosis like hantavirus, dengue virus, chikungunya, etc. And the local data in Tomohon's annual parasite incidence in 2022 showed about 0.69 per 1,000 population of local parasite baseline, and is signaling active local vector pathway. So the pathogen spillover pathway begins from wildlife reservoir, such as bats or rodents that naturally harbor the pathogens. Next, at the market interface, close contact between the different pathogens may facilitate the spread of infectious disease. And the last step is about those pathogens may adapt and cross the different species barrier, and it causing outbreaks in humans.
Yeah, now we move to the animal health, welfare, and biodiversity. Because it's the extreme market, like our concerns are, there are three. The first one is the workplace exposure, like wildlife workers constantly connect with wildlife animal. Like as example, the most case is rats and also bats that have highest contamination or pathogens like such as coronaviruses or paramyxo. And also there is concern of protecting endemic target too, such as macaca,
or yeah, monkey, endemic monkey that is critically endangered. So, and also Sulawesi anoa, as we know, that is endangered. So it's very dangerous because there are a close connection between human and also a wildlife animal. Next. And also, we got this data from BKSDA, or Natural Resources Agency, that there is wildlife trade circulation routes like from North Sulawesi. As we can see, there is a road through the line to a major city like Makassar, and also Kendari, and also yeah. Basically, it's a major big city in the Sulawesi, and also not only that, there is also routes from through the sea. As we can see, there is route to Balikpapan or in Kalimantan, and also in Surabaya, which is major big city in Java, and also to the Papua, to like to Jayapura and Sorong, and also Ternate, of course. But there is, that's dangerous even more, that not only locally in national but also internationally, like as we can see, there is a route to Philippines, the Davao City port. So the wildlife animal transported from Manado, or no, Sulawesi, North Sulawesi, to many region, nationally and internationally. Next.
Okay, and the third and after overlook, especially in our topic about extreme market, is pillar of one health is environmental health. Well, much attention given to humans and animal, but the environment also play a critical role in the transmission of zoonotic disease. Okay, the first issue is public ignorance. Like many people are unaware of the risk associated with consuming wild animal meat or interacting with contaminated animal product. This lack of awareness can increase exposure to zoonotic pathogens. And the second issue is pathogen persistence. Poor drainage system, organic waste, and animal offal create conditions that allow pathogen to survive in water and soil. Even after animals are removed, bacteria and virus may remain in the environment and continue posing risk. And the last, surveillance metrics. Environmental testing such as water analysis and surface swabbing can serve an early warning system. And according to WHO Indonesia, environmental surveillance helps identify potential contamination before it development into larger public health problem. As we can see in this illustration, so several environmental hotspots that can be seen in an extreme market. High contact surface such as display tables, as well as drainage and waterways area may harbor microbial contamination resulting from animal handling and waste disposal activity. And next.
Okay, thank you. This is about the active surveillance and response plan that we create. In the first place, this research doing by my friend, ongoing research, and we hope that it will go further and success. In the first place, we put surveillance response plan. This is the practical workflow, like we propose to deploy in Tomohon Extreme Market. We should check what the kind of animals that diperdagangkan in Tomohon Market, sell in Tomohon Market, and then we establish the supply chain tracing and data collection on the wild meat sold with eDNA. And then the second plan, the second one, we do we want to do the screening run DNA on diverse samples, including water, meat, dust, soil, air, cell stall, and skin swab from the traders atau pedagangnya. And then the third one, if zoonotic agents are detected, we coordinate immediately with the BKSDA, Natural Research Conservation Agency ya. Terus Health Department and the traditional leaders atau kita bilang pemangku adat ya, to run public education campaign and to mungkin mempengaruhi, influence the traders to not to do or masyarakat not to eat the wild Okay, and then the fourth, the fourth, this education leads to, we want to change the behavioral change for urging the local community to avoid eating the wild meat, gitu ya, the wild animal meat. And then the fifth step is we sterilize the market and expand screening to the consumers and local. And then we did the screening for the wild animal also, yeah. And the sixth step, we deploy a targeted clinical treatment for anyone detected with zoonotic infectious disease, which is a lot of risk in this place because a lot of wild animal sell in this Tomohon extreme market. And then the last, this complete loop ensure active surveillance and defense. We hope, yeah. Okay, next. Yeah, we go to the policy and government action.
Okay, thank you. Regarding the policy and the government action, the good news is our government in the national level or in the district level, there has been made a policies which is related to the veterinary public health and the animal welfare. Also in Tomohon itself, there is a mayor's instruction towards the regulation to eliminate, to control, and then to mitigate related to the outbreak in Tomohon. Next. Next, okay. Next. Yeah, so after all discussion that we give to you, there are at least 4 suggestions that we can give to the maybe national, province, and district government. The first one is integrated surveillance. Indeed, that this case is a very One Health related. It involves environmentally involve animal, also human. So the surveillance not only about the human, but also to environment, also the animal itself. Secondly, about the public education that has been mentioned by Mbak Sasa, it is clearly that important to give the education toward not only about the trader, but also to the community, to the head of community, also because it is a very cultural and complex situation, we can just collaborate with the district health office, district education office, and district industry office. And then the third and the fourth will get related to the regulation. The regulation has been made, but unfortunately, there is not mentioned about how we can mitigate, how we can stop the consumption of the wild animal. So yeah, I think we can suggest to the government, so they have to make a very specific and clear forbidden to the community to eat the wild animal. So yeah, next. Yeah, okay, it is the reference.
So here the studies we read last days, and the result is finalized from on the basis of these studies, and also our friend who is currently doing research on this topic. Hopefully we will success in our project. Thank you so much, and if you have any question, yeah.
Thank you very much, Group 5. So I think we've seen, a couple of years ago about how wet markets or the extreme markets be the suspect of the outbreaks, even the pandemic, right? but how is exactly that pathogen can jump from animals to human?
The main reason behind, Darwin, survival of fittest. Darwin, one concept, survival of fittest. The problem is we slaughter a wild animal. Wild animal have different diseases like hantavirus and so on and so on. So when we slaughter that wild animals like a rat, as I mentioned one study which is conducted by a prof who is in Taiwan, who gave us last lecture about coronavirus and so on. The coronavirus is by bat. Bat is also wild animal. It's the similar in extreme market in Sulawesi. They slaughter wild animal, and in wild animal there is diseases. So when we eat that kind of animals, which is not, I guess, which is prohibited to eat, but it's a ritual and the culture, people really want to eat that animal. My friend from Sulawesi, I already contact him last day. Oh, he said, oh, the cat is so delicious. And the mouse is really delicious. I already tried the snake and I already tried bat. So how we counter this kind of things? So this is our study based on.
I see. So, well, actually, people who consume those bushmeat, usually they cook it, right? So actually, like, I don't know, like most of the pathogens can be, cooked by several degrees Celsius. I mean, then how can exactly that pathogen jump from the animals?
As you know, for viruses, they really need specific kind of temperature, but they just cook directly like satay ayam, just directly cook, and they suppose virus already wap out from this slaughter thing like meat, but it is inside still. So that's why they directly consume, and that's why the disease appear.
Yeah, I think it's going to be very interesting to find one chapter about, how can those pathogens jump from animal to human. Okay, questions from the participants. Here, there, Pak, silakan.
Thank you. Everyone, I just curious about, is the children on local people Tomohon consume to the wildlife like rat, dog, macaca, and another that sell in this market, extreme market.
Yeah.
Thank you.
So I've talked with local peoples there in Manado there, and they eat it like because their parents eat it. They eat it like some kinds of rats. Usually it's rats and also bat wings. Yeah, they say it's delicious. Like one of my friends said that something like that, like chicken. Yeah, so because their parents eat it, so they also begin to eat it.
Like I also want to comment on my friend is also said the same thing, because my parents eat and their parents also eat this, and it's kind of ritual, and it's really delicious like a chicken and beef. We ever skip the pork if there is bat. We ever, even he is Catholic, so he said we ever skip the pork if there is bat. So feel how there is mentality there. So we need to focus on awareness, I guess.
Okay, thank you, guys.
Yeah, I think to find out or to identify the critical hazard point is very important here. I mean, to finally give a proposal how to end this transmission between animal and human. Any more questions? Yes, please, Ma.
Thank you. I just have a question. If the program is being run by the government and they create a task force to to tackle this problem, who do you think should lead the task force? Which department, whether from the veterinary or from the Ministry of Health or from the Ministry of Agriculture or the others? And who do you think would suit the best to lead the task force for this? Thank you.
Actually, right now there is, I already asked my friend, he said, yeah, because he still eat this kind of thing. And he said, oh, there is some kind of task force by district level and by government. Actually from government, like Pemerintah Indonesia, they still just aware, because if they directly vanish that kind of market, you know, it's ritual and culture. If they directly finish this market, so there may be conflict, like Papua or some kind of places. So that's why they still in the process of awareness, and the local government try to shrink that kind of market and give different kind of strictness or some kind. This is.
Yeah, in my opinion, it would be like Kemenko PMK that regulate the task force or something like that, and also it will be to the like governance of province, local governance, like governor or also in bupati, and also it requires many sectors too, like in the human health it needs dinas kesehatan or health health, what dinas kesehatan, minister, and also Bintan, dinas pertanian and peternakan for the zoonosis, and also DLH, dinas lingkungan hidup for the environmental. So we should do many multi-sectoral things to tackle that. Yes.
Thank
Please
you
add a
very
little,
much.
please.
Yeah.
Okay. Due to the fact that it is also a cultural issue, yeah, because it established in 1852 since under the Dutch colonialism. So I think we have to also involve the district culture office, because it is quite hard for the district health office or district industrial office to give intervention towards this cultural issues. So I think it is important, yeah, to also ask district cultural office. Yeah.
Thank you very much, Group 5. Actually, Mbak Rizna, in Jokowi's era, there is a ministry of Dok Alvin? Human and cultural development that is explicitly talking about One Health implementation there. In there, if I'm not mistaken, the involvement of three parties, like from the Ministry of Health and then the Ministry of Agriculture for the veterinary health, and then the lingkungan hidup, environmental, should be conducting all those strategies with the One Health approach. But that is only
on paper.
Only on paper. But right now, and the presidential era already changed, so probably we need someone to talk to the government about how important is One Health.
Sorry, you know, there is a concept in Indonesia, kerja bawa meja. So like they continue everything down the table. So my friend said, oh, there is extreme market, but even my friend's father running the shop and in that market. So they said, oh, if there is a local government come to close or shrink that market, they just give money from downstairs
I see. Yeah.
table.
Okay, great.
This is all about situation there, and that's why government is not involving, because if they involve, so there will be a conflict.
Okay, thank you. Thank you very much, Group 5, for the nice presentation. You may come back to your seat. And now we are going to have the next presentation from Group 6. Group 6. You still have more energy to listen to the presentations, right? Oh, Group 6 will talk about the AMR. Oh, this is nice. They already have the abbreviation COHAS. Kalau saya ingatnya jadi COAS gitu ya, Dok ya. Nah, itu dia.
Okay. Hi everyone. Hello. We are Group 6. There is Rega, Jessica, Henry, Nika, and me, myself, Duala. So today we will present our mini proposal based on the preliminary assessment in the Wonokerto village. Actually, we would like to thank the group 3 because they already present the context of Wonokerto village. So I don't think we really need to explain again to keep the presentation short and sweet, hopefully. So yeah, for our mini proposal, we try to keep it practical with strong community-based approach, especially in the prototyping phase. So why prototyping? Because it is impossible to have a robust solution since the beginning, simply because we don't know everything. So we need to prototype first. If we wish a system to work in a community, then we need to acquire several things. First, understanding human and non-human, the assemblage of both. And then being open-minded, it's really important. Iterate, adjust, reiterate again and again, adjust, and of course, evaluation, and so on. We need to refine our approach and system as needed based on the dynamic in the community and other finding in the futures. So being flexible and adaptable. So for further explanation, I'll hand over to Henry and Rega. So yeah, here we go.
Thank you. Thank you very much. I am going to continue on with our presentation. Just to give you a background on antimicrobial resistance, globally, many people, 1.72 million people are dying because of this issue. And it is expected the fatality of it is 5 million, but expect they come up with a report that by 2050, 10 million people will die because of this antimicrobial resistance. So here we can see, we saw the abbreviation, which is COH, COAS, we call it. That's our proposal system, surveillance system. And yep, that's it. So if you look back, people interacted with animals and they interacted with the environment. But because of knowledge, lack of knowledge, they did not understand. But thanks to research, thanks to knowledge that have come up, and now we are trying to understand the diseases that are interacted, happening in relation to environment and animals with human beings. So you see the proximity of people living. This is basically our observation from our field visit to Wonokerto. Yes, yeah, the place Wonokerto. Yeah. So you see, people live 10 meters, less than 10 meters with the animals. So the livestock, people live, they live closer to the people. And then you also see that in there are also pets, rodents that move around because they want to feed on the animals. And also, we found out that there was unregulated antibiotics use in that system, in that community. And so that gives us the understanding that if there is unregulated antibiotic use in the community, then there is a gap there for us to build a surveillance system. So our domains, which the team now is focusing, it will focus is these 4 domains, which is the One Health concept. So if we talk about human health, we will have to focus or monitor the fever and the diarrhea that is happening in the community. Respiratory symptoms, we have skin infections and zoonotic disease tracking there. And if you talk about environmental health, what is that? Sorry. Yep, the activity of rodents, you have the fly and the vector monitoring over there, and the waste disposal. Animals, if you look at animals also interact with the people there and the environment. So if we talk about this, we look at the mortality surveillance of it, the disease symptoms that may happen there. So yeah, here is the we call it the champions, the One Health champions. We will call it as the One Health champion. So these are the team who will be very responsible at the community level. And they will play a very vital role in monitoring and reporting the cases so that we can approach this at the community level. So we have the Pharma Group leader. They are very close to the community. Kadran, yes. Yes, thank you. And we also have a youth representative. Why we have a youth representative? Because of the technology, yeah? And technology is for this young generation. So they will have to be a person who is a youth to work on this technology that we will be proposing. And we also have a community health worker at the Worketo Wonokato Primary Healthcare and the village representative. So here is how the system works, the COHES works. This is our proposed system, and it's very practical at the community level. So we are not looking at someone outside expert coming to do the work, but the people in the community to carry out the work themselves. So monitoring card, we have a monitoring card. This monitoring card, the farmers will use to give the feedback according to what's some of the domains that we have mentioned, and environmental health and the others. So once they are monitored, they'll be sent through the WhatsApp group. And then from the WhatsApp group, the data will be integrated and shared among the key players of this. And risk factors, maybe they will present on this later, but I'll just give you the work plan or the action plan of it. And then we have the rapid. So here is this. If you see, look at the monitoring card. This is the system that we will want to propose to the community, for the community to take responsible and manage surveillance of zoonotic diseases that may happen. So this card, if you see who files it, it's the farmer, because the farmer is the person who is in contact of the animals and the environment every day. So the farmer will fill all this card. So once it's filled, they are presented weekly. If it's not presented after 2 weeks, that means that the place is out of risk. It's out of risk. But if he presents all this, tick all the boxes and present, that means that the place is the area needs to be what will I say? The key drivers, which are the puskesmas or the community health workers, needs to go and visit the area. So that's how it works. So you see, we have green, yellow, and red. Green means there is no cases there. That's safe. Yellow means there is risk there, increasing risk. So if the WhatsApp group, the domains that they select, and everything like 1 to 2 animals died, antibiotic use, all this happens there, we know that it's a risk area, so they will have to go. And then we have the red, immediate response. Within like multiple human symptoms, mass animal mortality, like animals die, a lot of animals die, and even if a death in the community, that means that place is very risky. It's in the danger. So that's how it works.
Okay, next is for the how we scoring the monitoring card, and here are the score for each checklist. You can see for the low risk, moderate risk, and high risk. And then this is the specific signal for detection the zoonotic risk factor from the human symptom, animal symptom, environmental symptom, and antimicrobial indicator. And for after we integrate all the data, we will assess the risk factors and alert the generation, and finally for the intervention to the community by the primary health care. And this is the time framework from our methods. First is about the foundation in month 1, and then deployment and trial. And this in trial, we will also monitoring how the farmer habit use the monitoring card, so we can know is the farmer can use the monitoring card, and is that will change their habit when he assess or monitoring the farmer. And next is about the evaluation, because we know that this is the system that need to the evaluation every first in 6 months, and after we evaluation we will development and refinement based on the data from 1 until 1 month until 6. Okay, next is the tracking for antibiotic, and for antibiotic antimicrobial resistant, we will monitoring use the card, and then we will sampling, and after sampling we will swab for all the livestock and environmental water sample and stool sample from human also to detect the parasite in intestinal human. And then we will also education for all the farmer that may be contaminated by the several pathogens. And next, this is the what we expect from the COHAS monitoring. First is about the early warning capacity, and then community involvement, risk intelligence, and antimicrobial resistance reduction, intersectoral coordination, and evidence generation. Because we believe that prevention is possible and start before outbreaks begin.
Short and sweet. Oh, we still have. Sorry, go on, go on. I thought it's the closing. Oh, it's the
Yeah,
closing, right?
that's the closing.
That's the
Although
closing.
if there is Jessica or Manika maybe want to add a little. No, we're good. Okay, I think yeah, we can go ahead with the discussion.
I see. So it's just like as promised, sweet and short.
Sweet and short,
Sweet and short.
unforgettable.
Unforgettable. Great. Any questions, comments, or suggestions? Yes, please.
Okay, thank you, Group 6, for this amazing innovation, I guess. Yeah. My name is Dikri, I'm from Bandung, and I want to point out to the community health workers. I saw that community health workers has such an important role, yeah, in the system. And we know that sometimes community health workers is like a volunteer, they are unpaid, and one person can hold a lot of programs like kader PKK, kader Posyandu, kader etc. So how do you manage in this system to encourage the community health workers to fully participate in the system from the first to the last? And secondly, how to monitor the effectiveness of community health workers' participation or contribution to really implement the system? Yeah, thank you.
Okay, so thank you for the question. How will we make sure that everything that will be the workers in this program will effectively works? It's like we're gonna make some training that we will to collaborate, and so that the farmers and also the health community will usually to
So for correct me if I'm wrong. So your question is how we incentivize, how we keep the health agency, health worker keep motivated, right? to
Community
work.
health workers,
Yes.
community health
For the-
cadres.
Yes.
Cadres, okay.
Yes. Yeah. That's interesting because from our understanding, they're not getting paid, right? So that's why we really need to map out the actors, so we don't burden only on community health worker. first, we also need to distribute the roles. So not everything is on their shoulders. That's the first one. The second one, to incentivize them. At the moment, we don't have an answer yet. That's why we really need to discuss, and we need to map out the power dynamic there, the decision maker, to find out the best incentive scheme for them. Because for now we don't have the answer, but thank you. That's a really good idea, because they, of course, they need to keep motivated to work for the community. And your second question is,
yeah, how you guys monitor regarding the effectiveness of community health caterers participation in this system?
yes, that's also things that we discussed yesterday. We're not a fans of pre-test and after test. Because usually it's on paper. Like before the test, like we ask them to see the bacteria, right? And then after that, and also we like the expert, they gave some lectures to the community health workers. And after that, like they had to fill the post test. And then based on that, usually like people, oh, the knowledge has improved. But that's on paper. What we really need to do is to involve the social scientists, the ethnographer, and then they will really live in the community for maybe, for example, 1 or 2 months or 3 months or maybe 1 month enough to really observe like day to day, day in and day out, not only the peasant, but the children there, and then the schools there, like the key players, the community, like basically the people. Do they really apply the things that they learn from the socialization event or something like that? That's the only one to really measure the improvement, the effectiveness of the socialization in the community. So not by the pre-test and after-test paper.
Okay, thank you.
Any question? Okay, this.
Okay, so maybe I can share what my organization has done regarding this, because we have some experience working with community health cadres, and maybe it could help answer the question. So as we know that Indonesia have the village fund, right? And this village fund is really big at the moment because the main government are putting all funds towards the village, and it's is being managed by, and it can be it can be ditentukan by the villagers itself. And there are posts for health, there are posts for say food security and etc. And for the incentive of health cadres, if the during the Musrembang, if you're all familiar, so Musrembang is a democratic agreement between the communities. They can put on paper like a berita acara. Sorry, like there's so many like Indonesian terms, but hopefully people understand. Berita acara that they are wanted to support the health cadres incentive because of their role in the community, especially like One Health Champion. That is a really good way to strengthen the reason for health cadres to be incentivized from the village fund. So, and in Borneo we've already had that. So the head of the village needs to regulate it through the Perdes. Yes, and it's the same as Kader Posyandu actually. So just keep in mind not to be overlapping between the two. And the monitoring is because it's under village fund, so it could be part of the village fund effectiveness monitoring system.
Yeah, that is a very nice one.
Yeah, that's a really good example. But unfortunately, each village they have different rules, different funds. For example, like yesterday we talked with the lurah, the village head sama yang aparat itu yang
Head
kemarin
village?
Yeah, the secretary, they mentioned that the dana desa, the village fund has been cut off, like for Koperasi Merah Putih. So that's also the future challenge. So they don't have enough money to pay for the cadre, unfortunately. So maybe.
Thank you.
Okay, so I have a question regarding during the presentation, you said you have like these studies that most of these, I don't know the cases, you have like mentioned that more like maybe 1 million or so. Okay, leave it. So how, and you propose that solution, which is like a monitoring card, right? To your like problem. Okay, so how do you see the mentality of the farmers? Let's suppose I will give you an instance. In during COVID-19, people get suffered, but they hide they have a coronavirus, so that's why it like increase. Do you see the farmer? Do you think that they will use like those tick box like boxes so that they know? Because once they do anything, they will like the team will come and surely they will quarantine their area. So how do you see? Because most of the farmers, they are like normal people, like they cannot afford such things. They do not like, how should I say, let's suppose I'm a farmer, so I'm not like dependent on the government, because I know once the government involved, it takes a lot time, and how will I earn, how will I eat, how will I feed my family? So how do you change the mentality? Though you have like the NINST, which is like problem, and you have solution, but how do you use that solution that which is like a monitoring card to the farmers, and how they can take the advantage, though they have like a limited mentality?
Thank you. Thank you very much. This is really a critical question, which I will try to answer. Basically, if you talk about their mentality, this is what you are explaining. Their mentality, their behavior, behavior towards, because agriculture is the main source of the people of income. So if you look at this, if they find out that this place has risk, they quarantine, and you don't have access. That's your answer. Question. What I'm trying to explain here is it's about their behavioral. We will have to, work at. The WhatsApp approach is very practical in that level. So if they can use it, and we will monitor it, it's important. But the point is how we can change their behavior to see that there is risk there. If you don't change your behavior, then you put the risk. If you don't change your behavior, you put the risk of everyone. You put everyone at risk. So who is it pointed? Is it you or people? Everyone.
But for us, because to be honest, this is the mentality of each and everyone here. Let's suppose I'm suffering from something, I will not tell because it costs a lot to me, and how will I feed my family there? No.
Yes. So most of this is from how we will focus on it. I assume it is not going to be to everyone. There would be someone in there to be affected, especially with this, like the mental perspective of how can I get income and to feed my family. So we target that person to really change his behavior, because he is the person that will make everything for the people to be affected. So we must have to target that person.
Yeah, because
from the
that is
community
how
level.
the diseases spread.
Yep.
People started hiding, and then that's why we saw the pandemic there. I mean, even in my city, there in Pakistan.
Yeah, this is very, very tricky as well, especially for the AMR or the antimicrobial resistance, since it's not a directed clinical symptoms. Usually in Indonesia, as Indonesian, if we not see directly the clinical symptoms, then we just, we're okay, so nothing to worry and everything, right? So how to finally give them an understanding about the importance of and how dangerous this AMR is. That is why you need some ethnography research, yes, to finally understand their behavior and then finally find the best intervention to cut the transmission or to stop the AMR.
Thank
Dr.
you.
Edwin, have comments? Or later? Okay.
Can I add it?
It's your thing.
Little bit. I think before we address about the mentality of people and things, we propose this kind of prototype because we are sure that this method can make us consolidate or select the farmers that already have a basic knowledge and awareness for, as a foundation to learn the lesson of the prototype. So we this kind of methodology, I think we also suggest to researcher because we don't have any assumption or judgment at first. I mean, we just running through and then we evaluate together with the community. So that's the principle of the prototyping method. Thank you.
Thank you.
Yeah.
I just wanted to add on his question, like first one, just to close it. I just like to differentiate community health worker and community health assistant. A community health worker is someone who been employed by the government, and most obviously they will have income. Community assistant is someone that is a volunteer. They just do work without any assistant, but it's voluntary work. So if you talk about community health worker, they are obviously government paid people and they'll be incentivized in ways where government comes in. And if you talk about community health assistants, they are the ones that we will have to, involve them. So one suggestion is when health programs go into the communities, you don't get people from different areas because there are community health workers who are there. If you choose them, it's part of incentivizing them. So any programs like malaria goes in, you choose them. If TB goes in, you get them in. So in that way, you build their interest, you also incentivize them, and you also boost their work in terms of community services. And that's one part of how you incentivize a community health assistant.
Yeah, that is very interesting as well. I think that would be all from Group 6. Thank you very much, ladies and gentlemen. Group 6, thank you. And now it's the time for the last presentation of this UGM One Health Summer Course. The second, Group 7. Oh, another AMR, Empowering Underserved Communities Against AMR in Yogyakarta. Ten minutes, start now.
Good afternoon, everyone. My name is Ashish. I'm from Nepal. I'm a postgraduate public health student here in UGM, and we're here to make our presentation. And we have also, selected a theme for Group 6. It's antimicrobial resistance, but we're more focused on empowering communities and its prospective intervention in terms of reducing AMR from the One Health perspective. Now moving on to the presentation. Can we please change the slide? This one? Okay. I'm sorry. The other one? Not this one? This. Okay. Sorry. So these are our team members. So introduction. So as already Group 6 has established about the magnitude of AMR in the world context. So almost 2 million deaths per year. So that's I believe that only describe about the urgency and how severe and the how effectively it has impacted among the world community. But I'm just talking about the Indonesian context. So about 40,000 deaths annually are happening in Indonesia from the irrational and erratic antibiotic use pertaining with the antimicrobial resistance. So because of that, Indonesian government has make a national priority of it and also implement a national action plan on AMR from the year 2020-24 using a One Health approach. So there are some previous literature that we found that the antibiotics are commonly stored at home. Many are obtained without any prescription. The people they usually store at their household about the different sort of antibiotics, and about approximately 86% of those stored antibiotics are without a prescription. From without a medical doctor or anyone who legally are authorized to make a prescription. So why Jogjakarta we choose as an underserved population and community in Jogja? So it's because Jogjakarta is a densely populated area. It's a combination of different sort of groups. I would say like urban. There's urban population here. There's a huge number of student population. There are also people from international communities. Followed by there's a huge practice of agriculture and livestock farming as well here in Jogja. So that's why we chose this region. And there are also several other evidences from prior literatures like Jogjakarta healthcare facilities, that has, from the passive surveillance that has showed, antibiotic usage and emerging bacterial patterns in community settings as well. So this is the causal pathway of AMR in pertaining with the Jogja. So we as a human were misusing antibiotics, like I said, without using antibiotics without any prescription, and that is followed by the use of antibiotics in poultry, like ayam, like bebe, and other livestock as well, in order to enhance their growth. And we're also enhancing their growth, but we're neglecting the fact that we should not overuse them. So for the monetary benefit, I guess we're just misusing it. That is followed by environmental contamination through wastewater and pharmaceutical residues of antibiotics. So this is the gap between antimicrobial use and AMR. So like I said, we're focused on underserved communities in Jogja, and because they remain vulnerable, and it is not just because of single misuse of antibiotics, but it's also because of the limited knowledge, inappropriate antibiotic practices, and insufficient community empowerment across human, animal, and environmental sectors. So the core problem is not just simply about the misuse of antibiotics, but there is also lack of community empowerment, community sensitization, and sustained engagement in order to use the antibiotic rationally or more responsibly. So we have not just focusing on the single silos or any animal, human, and environmental isolately, but we're more focused on the integration. Since this is one approach, we're more integratedly focused on all three aspects. So yeah, this is the basic, the gap, and this is what we have intended to do in our prospective research. Now I'll just give big respect to, just take it from me.
Okay, so we will deep dive into the methods that we used when we were in Wonokerto. So there are three methods that we use. The first thing is integrated capacity building and engagement. So the interventions began by mobilizing local community stakeholders and into a unified forum, and it includes cadre and smallholders, livestock farmers. And second is we conduct intensive and culturally adapted workshops focusing on the rational use of antibiotics and explain the explicit differences between viral and bacterial infections and the ecological danger of agricultural drug dumping. And the second method is educational evaluation via pre and post-test, and to measure the immediate educational impact. Visually accessible pre-test is been administered to all participants before the training workshop to establish baseline literacy. And following by post-test was conducted to evaluate knowledge and identify misconceptions and verify the cadre and farmers understand their surveillance responsibilities. And the last method is monthly participatory monitoring loop. And the first thing, human track on a monthly basis. TriNet cadre review village logbooks and conduct community check-ins to monitor self-medication trends and chart where community members are purchasing and prescribed antibiotics. And animal and environmental tracks, farmers log their monthly antibiotics usage per herd, and while visually survey potential hotspots where animal waste might contaminate shared community water sources. And last is the data feedback. Our monthly data fraction are aggregated using simple paper images or basic mobile messaging apps, and which are then set with the regional health center like a Puskesmas as an early warning system.
All right, moving on the expected result, direct system outputs of our intervention. First, targeted community literacy metrics. So we anticipated statistically significant increases between pre-test and post-test scores, which will demonstrate a robust shift in the community capacity to identify when antibiotics are biologically necessary versus when they are contraindicated. And the second, projected community-led database. So we expect the successful future generation of a functional, low-cost monthly registry mapping antibiotic usage pattern across human household and animal enclosure within the village. So together, this output will reflect improved community literacy and the establishment of a community-led surveillance system. Right, next.
Okay, next we look at three long-term outcomes of these projects. At first, we expect a major reduction in prescribed antibiotic per cases as literacy grows. The community will move away from self-medication and start refusing unnecessary drug use. And then second, we aim for sustained One Health stewardship. This means better farmer compliance with withdrawal periods and safer manure management to prevent antibiotics from leaking into the environment. And third, we see empowered local governance. This self-sustaining model proves that even in remote areas, local cadres and farmers can effectively mitigate AMR risks from the ground up.
Okay, and this is the discussion strength of the proposed model. In the community level, we have empowered local population and encourage ownership and improve awareness. And in the surveillance level, we have generates real-time local data, identifies emerging hotspot, and support evidence-based action. And for the One Health level, we have integrated human, animal, and environmental sector and encourage multi-sectoral collaboration. And we have also a potential challenge include the funding limitation, limited technical expertise, community participation fatigue, and data quality concern. Okay, and this is our reference. Thank you.
Thank you very much, Group 7. So this is the last presentation for this summer course. Any questions, comments, or suggestions? Well, I will start then. So in Indonesia context, there are some regulations about the prescription of the antibiotic or antimicrobial. For example, you cannot buy freely those medicine at the drugstore. And then for the animal side as well, they also have regulation about that. So it is illegal if farmers inject or give medication to their animals without prescription of the veterinarian. Then how it still happen in Wonokerto, yes, in your proposal? How is the implementation there? We have all the regulations, we have why it's still happening. How can you justify that?
Since it's this regulation still some antibiotics like that. ask a question. Sorry. Do you have any ideas like how it could be?
Hey, don't worry about that. I mean, you can find it. Okay. Sure.
I'd like to try them. So since you said they are heavily regulated antibiotics, but there was some, I guess there was some report, it being something, it's situation like where you could get antibiotics like an OTC medicine like over the counter drugs or something like that, and because of it I think I guess it's a more issue like a regulatory issue not being properly implemented or something like that, but I'm not sure, ma'am. I have to look properly about it. Since I'm also discussing about the friend about it, right?
Yeah.
Since there's a regulation, but there's some sort of implementation gap in terms of regulation, I guess.
Yeah, it
Could be
could
the
be
reason?
as well. Yeah, about the implementation gap of the regulation. Nice one.
Yes, ma'am.
Thank you. Any more questions, comments, suggestions? Oh, yes, please. Oh, where is the microphone?
Okay, see, you said like, how do they control? Because you cannot do anything. It's not. We are not supposed to force someone to stop, though illegal things happen even in Pakistan. So it's common. We just need to suggest some sort of awareness sessions so that we can tell them, and the government should be involved. This because they have some law. How should I say? Law enforcement agencies. They are supposed to protect the borders, so that they cannot get some illegal items there. And once you couldn't find in your area that there's such chemicals there, you cannot even vaccinate to the animal. This is how. What I believe, you cannot force to someone to stop. Yeah, they are free because this is what we call a freedom. So this is my suggestion.
Yeah, thank you very much. But I think regulation is still important to protect everyone, right? But how to do that, it's probably going to be very contextual. So different place, each side will have different approaches, right? Is that what you're talking? Thank you. That would be all. Group 7, thank you very much. What a nice presentation from all of you. We have various topics and all of you come from various background education. It's really, really amazing and interesting. Before we close this summer course officially, I would like to invite all of our facilitators that has already accompanied you since day one, since Monday, up until now. Dr. Edwin, Dr. Farida, Dr. Alvin, and of course the chairwoman of the summer course, Dr. Farah. Please come forward and have a seat. Dok, monggo mikrofonnya iya, jangan lupa mikrofonnya boleh diambil iya. Enggak dong. The same questions I asked to the participants first. How are you all today, doctors? After almost 6 days up until now for the summer course. How are you?
Great.
Oh, nice to hear that. Dok Farida, Dok Farah.
Okay, maybe it's also great.
I see.
We already have 6 days traveling and some activities. So
Yeah,
it's great.
nice to hear that. Dr. Farah?
So excited.
So
Finally, this is the end of the day. But actually, I'm so happy here to see all of the participants from around the world and then Indonesia across cities. Yeah? And I hope in the future we can still have a collaboration and then still in contact. If you have maybe many idea of maybe proposals like research or something like that,
you can call us.
Ah,
Yeah,
exactly.
yeah. We have Universitas Gadjah Mada, and then also we have many projects from lectures, etc. And then also the students. So please keep in contact.
Yes,
Thank you.
Dr. Farah. Dr. Alvin.
Yeah, I'm fine. Thank you.
Sure, I'm fine, thank you. Thank you. Well, so this summer course is like a hybrid format. We also have some participants online. Good afternoon from Indonesia. Thank you for joining us. We also have some courses on ELO, and then some activities, and then the field visit, and now the presentation, probably about the key takeaways, starting from Dr. Edwin, and probably the feedback from the presentations.
Thank you, Rima. Right. So, well, let's talk about the Wolbachia. I think. Yeah. I mean, like, I can't tell you the details, but I can tell you the one thing about is Wolbachia. Is it a bacteria, or is it a parasite, or is it something else? Well, Wolbachia is actually a bacteria. So we have two types of bacteria: gram-positive bacteria, gram-negative bacteria. A lot of differences, but one thing, the main topic is Wolbachia. It's actually an environment, and it's normally inside some of the mosquitoes. Culex, correct me, from the parasitology department.
Mosquito.
Yeah, and Aedes albopicus. But unfortunately, it's not available in Aedes aegypti. So what does it do? We want to have this bacteria in the Aedes aegypti. First of all, we inject it with Wolbachia, and then we hope to have a inherit of mosquitoes with that Wolbachia background very naturally, and then hopefully this dengue virus is unable to transmit to human. That's the Wolbachia technology. The details, not quite sure I'm allowed to tell you, but I've been involved in it a couple of years, 5 years, and this is what Wolbachia is important. And then the other one is about the question from the community, how the farmers are afraid to tell sensitive information, they might get closed down, isolate, and so on, so on. Well, the first possibility we do is community engagement. Community engagement is important. Like, how do we do that? Well, we involve the community. We let them inside the researcher, how we see the data, or how we see the patients involving a lot of AMR. So we do not just give them data. For them, data is something, what is it, not relevant for us. But when we engage the community, we let them know, we let them inside the research, we let them know what we do and what is the AMR capable of against the environment, against the human, and involving all the, the health issue, then we might able to let them know how important. And we have like maybe the one Group 6 champion in the community. It's quite important because they are the one who interact with the people in their community. So this is one way we can help or involve or inform the community that how important it is. So tell us the real information, and we can give you what it is important for. That's one problem, one issue. And then I answered 2 questions, right?
Already.
Okay, so what's the key point from this summer course? Well, one thing is like, think beyond your discipline. So I'm a clinical medicine, I'm a clinical microbiologist, but we have to listen to other disciplines. We don't just make our own discipline the majority, but in One Health, other disciplines is quite important, not just the medical point, but the environmental point. We have here Dr. Farah, she's a dentist, right? Dr. Alvin, Dr. Farida, Dr. Clinical Medicine, and Dr. Rima is a veterinary, right?
Yeah,
but that's not all. We have social science. Social science important for community engagement and so on. So think beyond your discipline. And the other key point is scientists or researchers get have resolution or solution, but that's nothing if we don't have a, what do I say, engagement in the community, the person who helps to implement this into the community. So I think that's quite important. And then early warning signs, for example, how do we know that? We went to the sites, so we know that there is a environmental change, climate change. That's one way to understand the early warning signs of One Health issue. And I think I'm talking too much, so I think I want to give this matter to other person. So who's next, Dr. Rima?
Hey, let's go to Dr. Farida then. Thank you, Dr. Edwin.
Okay, maybe I would just want to give a short review about this program. So I just want like to thank you about your engaging participation since day one. So you already give your best and you already have collaboration between many disciplines, between doctor, medical, or even engineering, or maybe from the sociologists. So you already have proposed a prototype or maybe a program that have engaging participation to the community, of course. And from this summer course project, maybe after this, you can implement to your community or to your environment. So with this One Health approach, you can do such good collaboration, maybe that.
Thank you very much, Dr. Farida. The interconnectedness between human, animal, and environmental, right?
Yeah, of
that can
course.
be applicable. Let's save Dr. Farah for later. Dr. Alvin.
Okay, so we have been here for 6 days, and it's been my pleasure to see your enthusiasm during lecture or field trip session. There are so many questions to the facilitator and also to us, and I think we also learn new knowledge from you all. And please do collaborate with each other after this summer courses has ended. We hope that you bring new knowledge to your field after this summer course has ended. Thank you.
As the chairwoman for this summer course, Dr. Farah.
Yes, maybe just a short message.
Okay.
I would like to deeply thank you, for all of the participants, for all of your contributions to this event. I remember when one of the speaker, he amazed with these participants because all the participants actively raised questions, and then actively discussed, actively engaged with this forum. They showed the enthusiasm. Yeah, many speakers say that, wow, this is very wonderful summer course. So this make us proud as the chairman, as the facilitator here. We are so proud to. So that's why we thank you for joining us and being a part of this summer course program. I hope this in the future we are, like I mentioned before, that we are still engaged, we are still in contact, and still develop a collaborations, because we are not like Dr. Edwin mentioned before, that we need to collaborate in interdisciplinary, multidisciplinary. Yes, like he said that I'm a dentist in undergraduate program, but after that I studied in tropical medicine, and then continue my PhD in Taiwan for biomedical sciences. So there are many disciplines that I already learned. So we have to extend beyond our competence, Jadi not only one discipline. This is also to contribute to our country, Yeah, maybe each of your countries. In Indonesia also, we have still many problems. Yeah, we have still maybe the second, for example, in TB, yeah, we are in the second rank, yeah, in the second rank, and then dengue, and then also yang kemarin apa campak ya po, measles also. That's the disease that we can prevent, but it still happen in Indonesia. So after this summer course, we can maintain our collaborations and also contribute to the community, to our country. Yep. Like Professor Chuang said that we need to educate people. Yeah. For example, like measles, we're facing anti-vaccine, yeah, anti-vaccine communities. This is our work also. This is our problem. So as we are in the One Health, yeah, in the One Health approaches, I hope we can contribute. I hope we can, building our competencies to make a contribution to our countries, maybe from Pakistan, Palestine, Bangladesh, yeah, and then what's again? US, yeah, of course, US, Papua, PNG, yeah, etc. We can make a better future for our countries. Yes, and then next, also, of course, for the facilitators, thank you so much. Thank you very much for this master's ceremony. Today, the Felicet and the teams behind, and thank you very much for all of your teamwork. And then for the participants, I am so greatly have a great gratitude to all. Thank you very much.
Thank you, Dr. Farah. Such a warm closing remarks. Oh, and one thing, after the presentations, I recognize one thing, the policy games become very important. I mean, after some topics that they chose, then it, end up with the funding and then the regulations and then the implementation. I think policy games also one of the highlight that we should be taken care of for the One Health approaches. Okay. Great. Any more additional pesan-pesan? Yeah, but before that, we actually have a sweet gift for you from the committees. Mas Roy, would you mind? I think you watched it already, but this one is made especially for you guys, for the participants. So, ladies and gentlemen, please have a look. One Health Summer Course. Thank you very much for your participation. Doctors, also thank you very much for accompanying us for these past 6 days. Thank you. And so everyone, there are some important announcements. The first one is about your participation on ELO. Make sure that you follow and answer the quiz, the self-reflections, everything to your ELO individually. So we know that you join this course 100% to get your certificate. And right after this, we are going to have a photo group session first, and then enjoy the lunch, the traditional lunch from our beloved city, Yogyakarta, with angkringan. That would be all. Dr. Farah, would you mind to close the summer course? Like, dengan ini kita tutup, oh enggak ya? With this, yeah. My name is Rima. I'm signing out. Wassalamualaikum warahmatullahi wabarakatuh. Sampai jumpa.